Hi. Hi. This is the fourth of our orthopedic series, and today Dr. Mayer will talk about total hip replacements. Dr. Mayer.
Thanks very much. It occurred to me when I was pulling this together that I particularly, and most of the rest of my colleagues, make too few opportunities to thank the people that make all of our patients better. And so I'm pleased with the chance to say good morning to all of you and to extend my acknowledgement and appreciation for the very important role that you play in getting the job done and getting our patients through their inpatient in-hospital procedures. What I'm going to try to do in the course of the morning is to give you a feeling for some of the history behind the development of the total hip replacement procedure, and give you a feeling for some of the current changes that are going on in the way we approach doing that operation. And there are a couple of patients whose films I brought along who've been recently reviewed here in the clinic, which will help sort of set the scene. This x-ray here is the front view of the pelvis of a 65-year-old gentleman, a retired farmer who came in with severe pain in the right hip over there and less severe pain on the left in 1980. And in 1981, he underwent right total hip replacement with a cemented acetabulum and a cemented femoral component in what at that point was the state-of-the-art approach. He's done very well. He's back tending his garden. As I say, he's retired from the major farming work he used to do, but his improvement has been so dramatic in terms of the pain he was having on the right that he is able to get along very satisfactorily without the need to trouble himself to have the left hip replaced. More recently, the x-rays that you see over on the far left are the AP views of a 30-year-old 6'2" high school graduate who works in the shipping department of a local firm, who has been having increasing discomfort in the left hip with a progressive problem, in part because of the pain, but also in part because of the less and less mobile joint that his left hip has been representing. And some of you may remember Kurt Belatet when he came in last year about this time. When he arrived, he was, as I say, in considerable discomfort, and he was unable to carry his left leg away from the midline. In fact, not only could he not bring his left leg out away from his right, it was actually drawn across the midline. So he was forced to walk with his left hip adducted, which made the left leg seem even shorter than it actually was. In addition to that, he couldn't internally rotate it, so it was stuck in about 45 degrees of external rotation. He was walking around like this in increasingly severe pain. What we accomplished for him a year ago today was the insertion of this biologically fixed AML with a screw-in Anderson cup. He came in, as I said, for follow-up. His walking pattern is absolutely symmetrical, so you can't tell one of the hips is abnormal in any way. He is completely free of any discomfort whatsoever and is only limited in his activities by the fact that I'm going to beat up on him if he does something I told him not to do. Even if he can't understand exactly why I said that, I want him very clear that there are some things that he should shy away from. So let me see if I can give you a little of the background in terms of how we got there and a little of a sense of where we might be going from here. Let me get the slide projector turned on if I could. It's the one on the left-hand side of the array there. And I just want to go through a few illustrations of the way the state of the art has evolved in the hopes that it'll provide a little bit of a setting for the circumstances in which we're working. The hip joint has been a problem for people for centuries, and as one of the things that goes wrong relatively frequently, both in terms of wear and tear and in terms of fracture, and one of the things that has been going wrong for a long time, it's attracted a lot of attention and attracted early attention in terms of trying to get some problem solved and how to use metal and plastics to create some improvement. The way things behave in both biological and mechanical terms, one seems constantly reminded of this basic truth. And it applies both to the patient's circumstance, what brings the patient into the office for help, and applies, unfortunately, also to some of the things that we can do in an effort to help. And from that point of view, we've got to be pretty clear about how all this works. One of the earliest challenges that resulted ultimately in the development of the metals and plastics that we're using are fractures like these, in which the subcapital bone of the femoral neck fractures, producing a piece here consisting of the femoral head that very frequently doesn't have a blood supply. And because of the difficulty in asking this piece of bone to survive and function after a break like this, and the difficulty in getting this break to heal, even presuming that you could put it in the correct position and then hold it there, these fractures are notorious in terms of how frequently they go in the wrong direction instead of the right. An orthopedic surgeon back in the middle 1940s named Moore approached a friend of his in the aircraft industry asking about alloys that might function well if they were placed in this position to take over for the broken femoral neck and the head. And the result of that interaction was the development of this device called the Moore prosthesis, which was intended only to take over for the femoral side, so it's a hemiarthroplasty. Dr. Moore, in his research into how workable this might be, asked his friends in the aircraft industry what they had for alloys, and they said, well, we got this material we use to make turbine blades out of, and it holds up pretty well in some pretty extreme circumstances and doesn't seem to corrode very much. Maybe that's a reasonable thing to try. So Dr. Moore said, well, why don't you make a couple of these, one on this shape and with this sort of a ball on the top. I'd like you to make a couple of those and give them to me. And so his friend did, and Dr. Moore took them from the factory, brought them home, dug a hole in the backyard and threw them in, covered them up and left them there for a year. And when he came back at the end of a year and dug them back up again to look at them, what he found was that this alloy, in fact, did hold up very well in the backyard under the dirt. And he was so encouraged by that finding that he began right away to do some clinical patients. That was the nature of clinical research in a significant part of the country back then. And fortunately, the choices were extraordinarily good, and we're still using the same alloy for this purpose today. This is the kind of problem we also face, in which the femoral head is compromised and the acetabular cartilage is also destroyed by virtue of a combined process in which both the socket and the ball are eroded. And the solution to that, which we've arrived at, is to resect the femoral head and neck and replace both the ball and the socket with something new. One of the early developments to do both the ball and the socket was the development of this all-metal device, which had a long threaded component that went up into the pelvis and a classic Moore-style component that went down into the femoral shaft. So again, this looks exactly like a Moore, the only difference being that the head is specially configured to fit in this metallic socket. These devices were developed in England by Dr. Peter Ring, and they had reasonably good success, but experienced difficulty because of the way the metal rubbed against the metal, producing lots of small metal filings which then stained the tissue and sometimes excited fairly severe reactions in the tissues around the hip. So we're constantly looking for an alternative method, and Mr. John Charnley, who eventually was knighted, was the one who came up with the idea of using this material here, which is methacrylate cement. And you can see the methacrylate cement, which is hardened and which has been forced into the cancellous bone. This is the spongy bone of the femoral head. And you can see how the methacrylate penetrates the porosity of the bone to an extraordinary degree, very intimately locking the cement and the bone together. That approach enabled Mr. Charnley to fill the canal of the femur and then push a stem down into that, and to fill the acetabular socket and to push a socket into that, and thereby reduce the pressure that the metal and plastic material is placed on the bone by increasing the total surface area. And you can see how the surface area, this is the outside surface of a piece of cement that was pressed into the femoral imaginary cavity. It molds itself to the complex shape of the inside of the femur and spreads the load over a very large area, reducing the load on any one piece of bone. That development, which came from dental science, Mr. Charnley was sitting in a dental scientist's laboratory complaining about the difficulty of making patients comfortable with these metal pieces in them. And the dentist reached in the drawer and pulled out this bottle of pink powder and threw it at Mr. Charnley and said, "Here, try this. We've been putting it in the mouth because that's what we make the gums and false teeth out of, and the tissues in the mouth seem to feel just fine about it, and the saliva doesn't seem to degrade it very much, so why don't you try this?" Well, Mr. Charnley took that powder, pink, just exactly the way he got it from the dental laboratory, and stuck it in. And by serendipity and good luck and a little bit of wisdom, it actually worked. As he evolved the technology, he was doing the surgery by taking off the greater trochanter, taking off the neck so that this worn out femoral head could be removed, hollowing out the acetabular surface, and then inserting the cement in this layer here to accept this plastic socket, hollowing out the femoral cavity to accept the femoral stem, and then putting the greater trochanter back down, but pulling it as far down as he could to make this tissue along the upper aspect of the hip joint as tight as possible. His thought being that if you did that, there was less likelihood that this relatively small femoral head would dislocate from the socket. Now, since then, the techniques have evolved. This is a classic Charnley with the metal stem. You can see the cement with barium in it, so it's visible. The cement in the acetabular component and the wire in the plastic cup so that we can see where the cup is, and we can see whether or not the cup is being worn against the femoral head because we can measure the distance between the two. And then these wires, which were used to put the greater trochanter back down after it was pulled as far down as possible along the lateral wall. And on the side view, again, you can see the stem in the medullary cavity, the cement, the femoral head, and the acetabulum, which is positioned so that it looks slightly forward in the pelvis. And we can look at a pelvis in just a little while to give you a better sense of that. Now, since the evolution of the Charnley arthroplasty, in which the trochanter was taken off, we began to experiment here with doing the same surgery but leaving the trochanter alone. One of the reasons being that taking the trochanter off and then putting it back on requires that the trochanter heal the way fractures do, and sometimes not the way fractures don't. There were sufficient difficulties with both the healing of the greater trochanter and with the fact that the wire, because it's fairly stiff, even with a healed trochanter, might fragment, break, and begin to wander around, that we wanted to find a way to get away from that. And so we began to work on surgical techniques that left this alone, still allowed us to get access to the acetabulum and the femoral shaft to put in these cemented devices. That worked out very well. We were approaching the hip from behind, so we made an opening in the back of the hip joint capsule, and we wanted to make sure that the patients in their convalescence didn't dislocate out the back. So you're all familiar with some of the positioning requirements that we imposed on those patients to try to keep that from happening. We'll look at some of the new approaches we're taking and begin to get a sense of what impact they may have on the management of the patient after surgery. An approach which we only used a few times here is the approach which replaces the rough femoral head surface and the rough acetabular socket with a very thin resurfacing device. There's a metallic shell which can be cemented onto the femoral head after shaping the femoral head, and a shell of metal and plastic which you can cement against the acetabular socket. The gains being that you haven't sacrificed any of this bone in order to get the new surface comfortable. What we found was that although that was very nice in terms of preserving the femoral head and neck, it required a very thin layer of plastic here, a somewhat larger hole to accept that shell. And when you put these back together, what you find is that the metal rubbing on the plastic, even though it's smooth, does exert enough force through friction and other phenomena that there's a lot of strain put on where the cement comes against the bone, and these things tended to loosen. When these very large shells loosen, you lose a lot of acetabular bone, and what you find out is that there are great difficulties in revising these when they fail. In other words, they're conservative in relationship to the femoral side. If this femoral side loosens, there's not much difficulty in converting this part to a regular total hip. If this part loosens, you realize that you've been radical where the acetabulum has been concerned, and you may be faced with a really difficult problem in terms of getting a good revision out of this. And so you'll see very few of these done anywhere now. And that gets us to the ultimate question. We are delighted, as I mentioned, in terms of both of these two patients and hundreds of others, with the improvement that everybody, almost everybody, has achieved out of the surgery that we're doing. And we've got to keep in mind that although most of the time this works very well, there are occasions when it doesn't. So it's worth looking at why it doesn't. When you look at the hip, you realize that the normal hip and the replaced hip both carry force over the whole ball. Again, depending on the position that you put your leg in, but there's a certain amount of force exerted in a distribution of pressure over the whole ball. When we look at this from an engineering point of view, we sort of conceptually take all these little forces and add them all together to see what they add up to. And what they add up to is this sort of an idealized force which is applied by the body to the head of the femur. And that's what the hip joint has to deal with. This force, when you calculate the way muscles function and the way your body acts in gravity, this force at the least is about 2.5 to 3 times what you weigh. And it's applied to the top of your femur, conservative estimate of 1 million times a year, if you're at all up and about doing things. Well, when you talk to engineers about how they test metal parts to see if they're going to break, they stop after about 1 million squishes. So a lot of what we know about the way metals behave is based on some fairly short-term testing in terms of what our patients are doing to their hips. Even 10 million cycles is really not quite enough. So you realize that these devices, these femoral components in particular, are being subjected to some extraordinary stresses and strains. The force is coming in 4 times body weight, not uncommonly, along this direction, and you can see it has a tendency to push the ball down in that plane. And if you look at what's going on at this point on the outside surface of this metal stem, what's happening is that it's being bent down, and the force that's being applied to the femoral head will have an effect at this point which is exerted over a lever arm about as long as this line D. So you got a force of easily 500 or 600 pounds being exerted on this ball, trying to bend this device around this place, and then you apply that in corrosive salt water 1 million times a year for 10 years, and one of the things that can happen is that the metal will suffer a fatigue failure, a crack will propagate across the metal, and the whole thing will suddenly decline. Yeah.
Understand 4 times body weight. How does that occur? I don't understand that.
Well, what you have to realize is that if you were to stand up and then shift all of your weight over onto your left leg, You could do that by just putting your shoulders over and then sort of teetering over your hip. Well, you're not going to get very far walking like that. So what you do instead is you actually keep your shoulders where they belong, and you shift your hips over when you walk, some more than others. As you walk along, in order to accomplish that and not have the whole thing collapse, you tighten up muscles, particularly these abductor muscles, very strongly to keep your pelvis flat and to control the progress that you're making. When you look at the way the hip is structured in terms of where these muscles go and how far away they are from the rotational point here, you realize that they're at a terrible disadvantage mechanically compared to where the force of your own body weight is trying to rotate your hip around this point in the other direction. And when you look at that, you actually discover it's about a 4-to-1 ratio in terms of how far away the muscles are working with their lever and how far away your weight reaction line is and its lever. They've actually done some studies putting some strain gauges on the neck of a Moore prosthesis and then putting that in patients who've had fractures, waking them up, letting them recover, getting them about 8 or 12 weeks out of the surgery, and then with various techniques measuring how much force the femoral neck is carrying. And it confirms that for walking upstairs, it's about 3 or 4 times body weight, and for running, it's between 5 and 6 times body weight. So the force is heroic. And as I mentioned, as a consequence, there are a whole bunch of things that will come up from time to time in relationship to this kind of a device. We've got a cement mantle around the femoral stem and a cement mantle around the acetabular plastic. And the kind of things that can happen, for instance, is that because you've changed the way forces are being applied to this bone may begin to disappear. If this bone disappears, then you may find that the cement and the stem are less completely supported. So the cement may begin to break up into little pieces. The body can react to the little pieces by actually forming a reactive membrane, which looks just like rheumatoid synovium. That will attack the bone and cause more bone to disappear. And now you've got a vicious cycle. The little pieces of bone cement irritate the tissues take away the bone, you get more motion, more pieces, more irritation, and finally the whole thing comes very loose. Then the whole thing can sink. If the support is lost from here up, this will be under such force that it may bend. You may then break it, as we saw. You may find that the greater trochanter has not stuck itself back down, and if you've used wire to reattach it, the wire may fragment and wander around and find itself in here. That's happened on occasion. You can do the same sort of a thing around the cup in terms of seeing that loosen. As a result of all of this mayhem, we continue to look for other ways to approach the solution. And of course, in the process of trying to identify all these terrible problems, we eventually bring you to the point of view that you think, gee, we're not going to be able to do any of this stuff without making everybody sick. Maybe some of them are actually sick and happy, but there are concerns that we have, and in the effort to measure exactly how we're doing, we try to make sure that we understand where those concerns are in the big picture. And in the process, we hope to be led to an adequate solution so that we can make judgments with our patients and get the right decisions made. This is sort of a graphic review of what happens when we're sitting in the office with a patient looking at the problem that exists in their hip. And what you find is that there's a range of activities that the patient expects, and this is important to be aware of. You're not talking about what the patient's doing now in terms of their accommodation to their bad hip. You really have to sit down with the patient and say, now, if your hip was perfectly okay, what would you be doing? And you might find out that this patient, who is retired on disability, would plan, as soon as the hip felt good, to start skydiving or some other extraordinary thing which would be very rewarding if only. So you have to know what activity the patient is going to launch when their hip feels terrific. And it's somewhere between 10% or less of normal up to occasionally more than 100%, if you consider what you thought was normal. And in the bottom abscissa here is the age of the patient, ranging from just after maturity up to over 80 years. As the patient's expectation for activity diminishes and the patient's age increases, you're more and more likely to be enthusiastic about arthroplasty as an alternative for that individual, because of the fact that the devices we have can put up with a reduced amount of strain, and if the patient's expectation for the device is less than 10 years in terms of how long they're likely to continue to jump around on it, you don't have very much hesitation to suggest that an arthroplasty is a good idea. In the very young and the very active, the concerns about whether or not this arthroplasty device is going to hold up become more and more severe. And at least 5 or 6 years ago, the conventional wisdom was for anyone in this area, hip fusion was a more reliable surgical procedure. Some interesting things have occurred in the last 5 years which make it very difficult to talk to a patient constructively about a hip fusion. Not the least of which is that patients understand how good the results can be from having their hip replaced, and they cannot imagine anything like as good an outcome from a hip fusion, which may put them in a cast for 8 weeks and may not fuse after that and require further surgery to get solid union in their arthrodesis. It's not to say we don't have patients with arthrodeses which are doing beautifully, and they are not as apparent to the world as the ones who are doing beautifully after arthroplasty. So there's a negotiation process which goes on in the office which is extremely active and very sensitive in an effort to discover exactly what the best approach is going to be. And in the gray zone here, things become most difficult. What we're beginning to experience is an increasing sense of confidence in the outcomes from the non-cemented arthroplasty devices, some of which is based on clinical experience, and a lot of which is based on engineering theory and the analysis of biomaterials that we've been able to do. In the process of exploring that alternative, what has come up is the possibility of reconfiguring the metal so that it has an extremely rough outer surface. And the one we're commonly using here is this AML stem, which you can all sort of stroke a little bit. This is the PCA stem, and there is a subtle difference between them. This is the Charnley, which is the original cemented one. In the effort then to deal with some of those concerns that exist about what happens to the cement, the fact that it not only is mechanically vulnerable, but as a biological implant, because of the way methacrylate and white cells interact, the cement creates an environment in which bacteria have an advantage. The white cells can't swallow up a bacteria as well if the bacteria is sitting on a slab of methyl methacrylate. So these methacrylate cemented devices are always at risk, even 5 or 6 or 7 years later, always at risk of being colonized by the chance arrival of a bacteria that gets loose in the bloodstream and circulates around. So we have to talk to these patients on a regular basis, both before and after their surgery, to remind them that if they get a pustule, a boil on their back, an infected tooth, if their gallbladder kicks up a terrible fuss, they get a bad attack of cystitis in their urinary bladder, any of those kinds of events which result in suppuration, those pussy infections have to be dealt with rapidly and effectively and should not be allowed to suppurate for any longer than is absolutely necessary, because we've seen those bacteria turn up in the hip or in the knee where cement has been used. One of the questions is, do these porous coated devices reduce the likelihood of that occurring? And there is theoretical and now some clinical evidence that it, in fact, is much less likely to colonize in terms of having bacteria set themselves up once the porous surface is fully ingrown. And this is what one of them looks like. This is one of the retrievals which we've garnered over at the medical school laboratory. We have a collection of over 300 retrieved specimens like this, which have been sent to us from all over the country. That collection is the largest in the world of this kind of human implant that's been recovered and analyzed to find out how the tissue and the porous coating work together. This one was sent to us by an orthopedic surgeon in the southeastern United States who has been very aggressive and cooperative in getting post-mortem specimens. I'm not sure why so many of her patients turn up dead, but we're pleased that she's thinking of us when they do and that her patients are willing to offer these specimens. This was an elderly lady with osteoporosis who a year before had had this implant put in for degenerative arthritis. And what we've done is the doc who was taking care of her and who put this in actually sectioned the femur here and produced a big piece of bone at the pelvis as well and sent the whole kit and caboodle up to us intact. So we were able to examine it, photograph it, strip off the soft tissue, the muscle and the ligaments, and then divide this femur in half like a clamshell and pop the top off. When we did that, we saw this coated surface with cancellous bone densely ingrown here, and the smooth part of the stem, which is just like the one that you're looking at, goes from here down, is coated with this very thin fibrous membrane. When you look at it closer, you can see the beads of the coating, the cancellous bone, which is a beautiful lacework scaffold, and the cortical bone in close apposition, and lots of bone bridging between the cortex in several places and the metal stem. This is perfectly comfortable, by the way, in terms of the patient's experience. When you look at the metal and the bone under a scanning electron microscope, you see these little balls, which are how the coating is made. And you see how the bone fills all the voids. If you look at the balls before the bone grows in, what you see is that they're all sort of welded to each other where these little necks are. And the welds are achieved by coating the whole thing with a gooey organic substance so that the balls all are kind of stuck to each other and then stuck to the stem. And then you put the whole thing in a furnace. And you bring the temperature up far enough so that the surface of the metal gets a little liquid and starts to flow, but you don't heat it enough to melt the whole thing. And when it starts to flow like that, it basically, anywhere these touch, it runs into that gap and fills the gap with this beautiful little fillet and leaves these big voids among the balls into which the bone is invited to grow. And this is old bone here, and this is new bone. All of this is bone that's grown since the implant. You can see it just goes roaring right in to all these spaces and will occasionally appear plastered right against the solid part of the stem. When you look, we've looked at hundreds of these now to try to find out how the tissue looks. Is there anything about this soft tissue here, this fibrous tissue and blood vessels here, anything about the bone that would suggest that there's any unhappiness to this relationship? And in no instance have we seen any reaction which would be at all construed as ominous in any way. So this is beautifully accepted by the body. And as I mentioned, does, if the mechanical situation is quiet enough, encourage bone to dive right into the spaces among the balls. And it doesn't seem to matter how big these are, and you can tell looking at those two that you were looking at that some of the balls in the PCA are big and the balls in the AML are smaller. They both work about equally well if their mechanics are good enough to keep them quiet when you first put them in. It also doesn't seem to matter whether you make it out of this chrome cobalt material, which we've been talking about, or titanium. Here's a titanium stem, which has sort of a Brillo pad that has been fused in something like the same way. And if you can get everything quiet and keep the metal and the bone close to each other for long enough, the same sort of thing will happen. Around the smooth part of the stem, here's the end of the coating, the smooth part of the stem, you inevitably find this fibrous membrane. And the question we've been trying to answer is, does this fibrous membrane have nerves in it? So we've been looking with special stains to try to find nerve fibers in this layer. My sense is that it's likely there are nerve fibers in this layer, or at least very close to it, and that's one reason why the old Moore prostheses, which were smooth all the way and all formed this membrane, were all a little uncomfortable. Talk to a patient with a Moore prosthesis that was put in without cement, they all say, well, I'm all right, but when I first get up and take 1 or 2 steps, I have this pain down the front of my thigh, and it doesn't bother me too much. And it usually goes away after the first few steps. We actually find that some of these patients with these porous coated devices say the same thing for about 6 months. And one of the concerns is that as these devices evolve, some researchers are trying to find out how small a surface can be coated and still have a good outcome. As this coating gets less and less of the whole surface, and the smooth part gets more and more of the whole surface, the patient has more pain for a longer period of time. And that's the trade-off. We're looking at the question of where we ought to end up in the long run. Here's the marrow, the old bone, some new bone, and there's the fibrous membrane. This is the metal of the smooth part of the stem. So this fibrous membrane exists in all of the ones we've looked at so far, outside of the area of the porous coating. In the area of the porous coating, you don't see this gap between the bone and the metal. What's going on now? This is, by the way, a magnetic resonance image of the hip. You can see the femoral head with the marrow showing up as a very bright image because of all the fat and water in it. The spine, this is the iliopsoas, the psoas part of the iliopsoas muscle. All these dark areas are muscles, and these are the abductor muscles that we mentioned before that are pulling when you put your weight on your leg and keep your hip from dropping down like this when this leg isn't bearing any weight. Well, one of the things that we're doing now that we weren't doing before in relationship to gaining access to this part of the hip, and we can bring the lights up a little bit so that I can show you a little better. If this then is the hip joint, and it's the left one seen from in front, the approach we were taking before with the Charnley was to lie the patient down and to make an incision right up the side. We would then take off the greater trochanter, which would allow all this to come up out of the way and then get into the hip joint that way. As the technique evolved and we wanted to get away from taking the trochanter off, what we were then doing was to put the patient on the side with the surgical side uppermost. We'd make the incision around toward the back. We'd come in underneath these muscles and open up the capsule back here and pop the femoral head out backwards. The problem with that is that when the patient sits, they stretch that part of the capsule that we've made an incision in. And if they sit and then bring their leg over and then rotate internally, out it goes. What we're doing now is we're taking the patient, putting them up on their side, making this straight lateral incision, just like the one we used to make way back when we were doing Charnleys. And we come down on this area, and instead of either going behind or taking off the trochanter, what we're doing is we're splitting the abductor muscles. So we're leaving half of them behind and taking half of them away in front. And we're doing that going down here so that this part of the greater trochanter is peeled with little flakes of bone being pried off so that all the fibers that come in to attach to the greater trochanter from above are still hooked to little chips of bone. We actually do that below as well because there's a big muscle, the vastus lateralis, which comes up and also hooks onto the greater trochanter. We chip that off so that the vastus lateralis and the anterior abductors remain in continuity. So there's no tendency for these abductor fibers to pull away going upwards, no tendency for the vastus lateralis to pull away going downwards. This whole soft tissue envelope is then rolled forward. We come down on the capsule, and actually we've done that with this one. So we come down on the capsule like this. We take the capsule off going anteriorly as well, so that the whole thing, the whole soft tissue layer in front, is pulled off forward, and then we rotate the leg externally and pop the femoral head out of the wound. We hollow out the femoral medullary cavity, move this out of the way so that we can hollow out the acetabular fossa. We put in the acetabular component, bring this back out, put in the femoral component, and then reduce the whole thing. When we reduce the whole thing, these soft tissues then fall back into place, and all we have to do is hold them together front to back, because no forces exist that are not balanced that would tend to pull things apart. The difference, though, is that everything back here is undisturbed. Things up in front have been disturbed some, so when the patient's lying there in the bed, the thing we're actually concerned about now is that they might swing their leg in, extend it, and externally rotate. So there's a little different set of concerns that we have with the change that we've made in the surgical approach, that the patients we're dealing with now need to be protected against external rotation even more than they need to be protected against internal rotation. And it's for that reason. Yeah. Mostly because we're not too concerned about what might happen when they sit up. Since we've left that whole posterior envelope of soft tissues alone, those are all intact, they can flex their hip and their knee. Flexing their knee will keep them in neutral, and any pressure that's brought to bear on the tissues posteriorly will be very readily accepted because those tissues have not been disturbed. So it's that and the combination that the tissues that have been disturbed up in front have been essentially parted like a curtain. And then when we let go, their tendency is to fall back together. The one maneuver that's going to put some stress on those anterior soft tissues is to have your hip flexed and then actively try to flex it further. Because when you do that, you tend to balance the inclination of the hip to rotate by pulling on your anterior abductors. And when you're flexed, your anterior abductors are coming down from in front, and they may try to pull a little bit on that anterior closure. But that's the only kind of stress that's likely to disturb anything. And patients seem to be more comfortable with that long continuity of tissues that goes all the way from the iliac crest down to their knee, essentially. So they seem to be able to get back on their feet and have the freedom to move more comfortably than they had when we were doing more disturbing surgery in terms of changing the anatomy. Now, one of the problems is that it's slow for us to communicate to you guys with a change in routine that we've changed our routine. It's also a problem because there are 7 of us, and we may not all change in the same direction at the same time. So if it wasn't bad enough, it's even worse since not all of us are uniform in our approach to how we do this. Generally speaking, though, most of us are taking this approach now with most of our patients. In sort of the overall sense of what's going on, Alexander Pope, I think, had a very succinct piece of advice, and it's the balance between staying in history too long and launching too radical a change from what is familiar. In the process of trying to get our patients from where they are to where they want to be, the balance of those issues is extraordinary and delicate. But it's also fun, and that's the end. Well, that's a very interesting issue, and I can't pretend to be able to tell you how that's going to come out. There have been some interesting studies done in Boston. Right now, they're limited to an evaluation of how the upper femur changes with age. The upper femur changes with age in such a way as to get larger in diameter both in terms of the outside measurement of the cortex and the inside measurement of the marrow space. Theoretically, if you have a femoral stem in there, it's going to start to rattle around. The problem that comes up is the figures that show that change in the way the femur behaves are all based on femurs that are intact, with the normal femoral head, muscles, and the rest. The changes that you introduce when you lop off the femoral head and put in a metal stem are so profound that they are going to change the response of that structure, because bone is a very lively material, and it does things in relationship to the mechanical process that it perceives. And one of the reasons it gets bigger is that it is also getting more porous. The osteoporosis seems to be a fundamental change which alters the amount of bone in the femur. If you look at the engineering of that, and you're going to have a tube whose wall is getting less robust, and you still want it to do something significant in terms of carrying your weight, what you'll do is you make it bigger. And the thinner the wall, the bigger the diameter in order to do the same job. Well, Mother Nature knew that a long time ago, and that's what she does. So what happens then when you change that by putting this huge metal stem in? Don't know. So far, I have not seen any scientific evidence that osteoporosis, as it progresses, results directly in loosening of either the cemented or the uncemented device. And it's a judgment call now in terms of what we decide to do in an elderly patient who needs a total hip. Are we going to go with a cemented system with which we have 20 years of experience? Or are we going to go with an uncemented system with which we have a little more than, well, almost 10 years of experience now? If you go all the way back to the hemiarthroplasties we were doing in '76, we've been following patients with this kind of an implant for 10 years. And those patients have not shown adverse changes. And those patients, the first patients we did were elderly patients with hip fractures who needed a hemiarthroplasty and got one of these devices with this sort of a femoral head, so that these were put together like that, and this was moving in the acetabulum, and the femoral complement was moving in the plastic liner. This is the bipolar or bicentric design, which we will sometimes put in if we feel the acetabulum has a reasonably satisfactory quality. So that's what we were doing back in '76, and those patients we followed since then have all done very nicely, even though they're largely female and largely over 70. And so many of them do have osteoporosis, and they seem to be doing very nicely with this device.
That is considered a total hip, also a bipolar?
No, it's a hemiarthroplasty. It's half of a total hip. The total hip really is reserved as a term, reserved for the replacement of both the socket and the femoral head.
And as far as weight bearing tolerance, or I think in some hospitals don't they go directly to full weight bearing right away? I was wondering
Yeah.
what decide how much weight you can do if you don't actually.
If you leave the graded trochanter on, and you can count on the rest of the musculature being more or less in continuity, the only theoretical reserve that you might use to justify waiting for full weight bearing is concerns about the readiness of the bone to carry the new load, because the load has been radically changed when you put in one of these devices. There are experts in bioengineering who would suggest that the interface between the implant and the bone of the host is an analogy with a fracture, and that you need to have the same kind of adaptive responses occurring after you've finished a total hip that you have after you've finished breaking your leg. So you need to have some time to spend so that adaptive changes can occur to give support. There are some who've done enough of these porous coated devices in a wide enough variety of people so that they can say, well, I tell everybody not to bear weight for 2 months. And the ones who ignore me seem to do even a little better than the ones who do what I tell them. Well, we need better science than that before we can say, okay, go to it. Some of that's beginning to accrue. For instance, there was a study at special surgery of patients who had bilateral simultaneous knee joint replacements. And there were almost 100 of those individuals in the study. They compared those people with a matched group of unilateral knee joint arthroplasties to find out how the two groups did and was there a discernible difference between them. Expecting that if getting up too soon was going to be a problem, the patients who had both their knees replaced would certainly demonstrate that problem. And they thought that probably the problem would come up most clearly would be loosening. In fact, the patients who had both knees done at once had fewer incidents of loosening, fewer incidents of deep vein thrombosis, fewer incidents of infection, which is a little hard to figure out. Generally did at least as well as the ones who had their knees done one at a time. That's not to say that in terms of the stress on the patient as a whole, they didn't have a bigger hurdle to jump, but given that they got over that, they did at least as well as the ones who had them done one at a time. So there is beginning to be an assessment that says, well, yes, this is a very conservative approach, and it may be more conservative than it is necessary to be. We still tend to tell patients to take it easy for the first month and a half to 2 months and try to keep them using double support at least until their first visit at 4 or 6 weeks in the office. At that point, if the x-rays look good and they seem comfortable, what I usually do with the hip patients is to tell them to gradually increase their weight bearing until they can support themselves with simply one crutch on the side opposite their new hip. And try to keep them doing that for the next month until they reach the 8-week anniversary of their surgery, at which point, both clinically and with our retrieval studies, it appears that solid bone ingrowth has occurred as a commitment to that porous coating. And as, for instance, with this patient that I mentioned before, Kurt Bellatet, who came back a year later with this Anderson cup and AML stem, and there's an Anderson cup here with the threads that you can play with a little bit. His x-rays demonstrate a very substantial fixation of that femoral component and the acetabular one as well. And clinically, as I said, you can't tell which of the two hips was operated on, either in terms of his range of motion or in terms of his